Thank you, everyone, for taking the time to come here and listen to our congressional briefing. I'm going to get started. My name is Jordan Marshall. I'll be the moderator for today, and we'll introduce our speakers in a little bit. This congressional briefing is called Food is Medicine, Specialized Nutrition, and Patient Access in Clinical Care. So I currently serve as the Director of Government Affairs for HNC. And for those who don't know, HNC represents manufacturers of enteral nutrition and oral nutrition supplements. That includes categories such as medical foods and parental nutrition. Right now, HNC's mission is to improve patient outcomes by we have another guest. Improve patient outcomes by advancing nutrition policies and advocating for patients who we want to ensure have the specialized nutrition care needs met. So right now, I'd like to give a special thank to Rep. McGovern and his staff for preserving this room today, as well as being a champion in the medical foods and specialized nutrition space. I'd also like to thank some of our supporting organizations. So the Academy of Nutrition and Dietetics, Improve Care Now, NASPGHAN as well, which stands for the North American Society for Pediatric and Gastroenterology and Hepatology and Nutrition. So a very long name, but we appreciate their support as well. And right now, I'd just like to take a time to say that we're especially grateful to have Representative Jim McGovern here today. I'm going to give a brief introduction before he comes up to provide some remarks. So Congressman Jim McGovern is a longtime champion of anti-hunger, nutrition, and food security initiatives in Congress and currently serves as the co-chair of the bipartisan Food is Medicine Working Group, as the senior member of the House Rules Committee, and a nationally recognized advocate for ending hunger. He has led efforts to strengthen federal nutrition programs and elevate the role of nutrition in improving health outcomes. He also is the lead sponsor of the Medical Foods and Formula Access Act of 2025. And this legislation is aimed at improving access to medically necessary nutrition therapies for individuals living with inherited metabolic disorders and other serious conditions. So please, once again, let's welcome Congressman to the podium.
Well, thank you, Jordan, and thank you all for being here in Washington. It is really important for you to be here to talk about the issues that you're discussing, because I'm going to tell you a little secret that may come as a shock to some of you, but intelligence is not a prerequisite for serving in Congress. And so we need teachers to come and teach us about what works, what we should be doing, what we should be focused on. You know, somebody asked me on the way in the meaning of these Tibetan prayer beads that I wear, and these were given to me and blessed by His Holiness the Dalai Lama 2 years ago when I visited him in India, and I've gotten to know him over the years, but he gave me these. He told me that it helped with my worries, my anxiety, my fears, and my negative thoughts. And I'm anxious to see him again to tell him they don't work. Because a lot of the stuff that's happening here right now seems contrary to a lot of the goals that the people in this room are dedicated to. We just had this wacky debate on the House floor that just didn't make any sense to me, and we may come to a grinding halt prematurely before the July 4th recess. But I'm from Massachusetts, and Tip O'Neill was the former Speaker of the House, who used to say all politics is local. And I think with some of the people running this show down here, I think all politics is loco. It doesn't make any sense. But I want to wish everybody a good afternoon, and it's great to be here with all of you. I want to say thank you to the Healthcare Nutrition Council for putting this event together, as well as for your tireless work to improve patient access and increase education around the relationship between nutrition and health, which on one level seems so obvious, but yet when you look at our system and the way we do healthcare, it isn't so obvious. Every year, thousands of kids and adults are diagnosed with digestive and inherited metabolic disorders. Oftentimes, medical nutrition is the best or only treatment for these diseases. All of us here know this, but it's important to help others understand that we're not talking about over-the-counter vitamins or supplements here. These are specialized foods and formulas that are necessary for the management and treatment of these complex diseases. Medical nutrition is healthcare. Food is indeed medicine. But the sad reality is that most people can't get medically necessary foods covered by their insurance. This means that many families are faced with an impossible choice: pay outrageous costs and forego sometimes life-saving treatment. That is unconscionable, and it doesn't have to be. And that's why I have been a longtime sponsor of H.R. 5684, the Medical Foods and Formulas Act, formerly the Medical Nutrition Equity Act. Representative John Rutherford, a Republican from Florida, is my co-lead, and our bill would require Medicare, Medicaid, CHIP, and FEHBP to provide coverage for medically necessary food. It's a narrow bill that would provide much-needed assistance to patients and families that have been prescribed or ordered medical nutrition as treatment from a healthcare provider. We have the tools and we have the resources to give people access to the very best treatment. But instead, people with digestive and metabolic diseases live every day unsure whether they'll be able to afford the treatment that they need. We have the means to improve many people's quality of life, and so I believe it is our duty to do just that. I'll also add that I'm pushing Congress and this administration and even private industry to do more to improve access to food as medicine. I have led the effort in Congress to increase coverage of medically tailored meals, expand nutrition education at medical schools. I mean, it's kind of astounding to me that in some medical schools that soon-to-be doctors aren't being taught about nutrition, and to ensure that HHS continues to prioritize food in the prevention and treatment of chronic disease. I mean, if we want to improve treatment, and we want to improve outcomes, and we want to improve lives, nutrition and medical foods have to be part of the conversation. I had legislation a while back when President Biden was president that we passed that established the second ever White House Conference on Food, Nutrition, Health, and Hunger. And in the first conference was in 1969. This is the second ever conference. It was a good conference. There was a good report. Unfortunately, the political winds changed around here, and we're not following the advice that was brought to everybody's attention at that conference. But we just have to do better, and I think we will if we're persistent. Let me just close with this. It is no secret that we are witnessing a full-on assault on health care and access to nutrition benefits for the most vulnerable among us. People all around the country are being crushed by health care costs and are losing coverage at a record pace. We just had a debate on the floor, and I was recounting stories that have been told to us about people from all over the country whose health care bills, doubled and tripled and quadrupled, and some have decided to go without coverage because they feel okay and they figure, you know what, I just can't afford it. It is more critical now than ever that we are pushing back and advocating for the expansion of access. It is crucial that legislation coming out of Congress reflects a desire to help people and not hurt people. And I would also say that what you are all advocating today is not only about helping people. If all you care about is saving money and controlling costs, what you are advocating for does that as well, because it helps people manage these very difficult conditions. So I know that everyone in this room is committed to that fight, and I'm grateful to be in it with you. We are available to any of you if you have ideas or suggestions, or you have good intelligence about how we might be able to expand the co-sponsorship of this legislation. But I'm a believer in this, and some of you in this organization have been critical in converting me to being a believer, and I just want to say thank you. You're doing the right thing. We will succeed. The question is how quickly we will get there, and I want it to be sooner rather than later. So have a good rest of your meeting. Thank you, and welcome to Washington. Thanks.
So, it was great to have the member swing by and have some remarks. For our objectives today, it's simply to learn about the barrier to patient access of specialized nutrition therapies and federal solutions that can make a difference. So we'll be discussing 3 bills today. We're going to identify the differences between medical foods, oral nutrition supplements, and conventional foods, and then also just recognize the necessity for medical foods and oral nutrition supplements and some of the challenges for patient access. So right now, I'm just going to give a brief overview on this spectrum of specialized nutrition available for people who have different diseases and conditions. So when we're talking about parenteral nutrition, is fed through the vein with an IV for someone who cannot use their gut. Enteral nutrition is liquid nutrition that is fed through the feeding tube into the gut or can be taken orally. In either case, with parenteral nutrition or enteral nutrition, someone could be prescribed either of these as a sole source nutrition or supplemental nutrition, depending on their situation. Some examples of enteral nutrition would include specialized oral nutrition, including medical foods or oral nutrition supplements, or ONS. These are regulated under the terms of the food or for specialty dietary use, which we'll talk a little bit about later in further detail, but both of them can be prescribed or recommended for the sole source of supplemental nutrition. And then when we're talking about medical foods, they're meant to support certain diseases or conditions or physical impairment that impacts the ability to eat normal, conventional foods. They're usually uniquely prescribed and formulated to meet the unique needs of an individual. A quick example would be a medical food for someone who with an inborn error of metabolism, and their body is unable to digest or metabolize certain amino acids. So in this case, the medical food that is recommended would be a complete protein minus that amino acid that would otherwise be harmful to that person. If we're talking about oral nutrition supplements, they are nutrient-dense foods or liquids that someone could take, and they are recommended by healthcare providers. They're especially used in cases of malnutrition to help prevent or alleviate the risk of malnutrition. We have often heard stories of patients who use ONS as a meal replacement. They are sometimes used when patients just cannot otherwise tolerate a meal. And in terms of specialized nutrition products, they differ from conventional foods because they can be used in every day depending on the person, and they do have different labeling and regulatory requirements that we're going to talk about later today, and they are just handled differently in insurance plans or with food assistance programs. So most important thing today is that food is medicine is an initiative, and that there's bills that are out there and that should recognize that there's a spectrum of nutritional needs, and that people who use these kind of products are important, and not everyone can eat these conventional foods, and we want to recognize the voices of these patients when we think of the food is medicine conversation. So additionally, just wanted to talk about some other things as well. Let me go back here to just saying a quick overview of medical foods and oral nutrition supplements. They have their own unique regulations that are different from conventional foods, dietary supplements, and pharmaceuticals. These products are specifically formulated, and they might be used as a sole source nutrition. So, they are life-saving. As we talked about earlier, they fit into this food as medicine conversation, really their needs need to be considered. So they also help prevent malnutrition, and they are certainly a very costly disease to our healthcare system overall. And people who are impacted by malnutrition can cost the healthcare system upwards of over $100 billion annually. And in this particular case, we have data that suggests that it'd be over $150 billion annually. Here, we're just trying to show that this is a slide that's has a little bit more data to it, but just saying that the main thing is to understand here is that, malnutrition, it can be very expensive. There are unintended consequences of malnutrition, like hospital readmissions rates. There are a lot of older adults who are especially at risk for readmission and malnutrition risk as well. And ONS, so oral nutrition supplements, are a tool that could easily help to treat or prevent malnutrition overall. So, they have been proven to help save healthcare costs, and our speakers will be talking a little bit more about those nuances later today. And then right here, I just wanted to provide a brief background on ONS products. So, they are used in clinical practice guidelines. They do have some insurance coverage depending on the plan, and there is some HSA coverage with medically necessary documentation as well. So, they're also available over the counter, and they are certainly recommended by healthcare providers overall. And then lastly, I just wanted to kind of mention that similar with medical foods, they are a little different here in this sense, but they are also included in the clinical guidelines for patient care and use under the supervision of a physician. Also, health insurance is really going to vary across the spectrum, and then just like the big takeaway here is that access can be a challenge. So if we're thinking about, insurance can be difficult, and that's going to be part of our discussion today, addressing those issues. And now we're going to get into our speakers today. Kelly D. Horton, she is a registered dietitian nutritionist who currently serves as the Senior Vice President of the Public Policy and Government Relations at the Academy of Nutrition and Dietetics, and she leads federal advocacy efforts to expand access to evidence-based nutrition care and improve healthcare outcomes through policy. We also have Dr. Carol Green with us as well, and she's a professor of pediatrics and an OBGYN at the University of Maryland and is a board-certified clinical geneticist specializing in inherited metabolic disorders, newborn screenings, medical nutrition therapies, and has decades of clinical policy and patient care experience. So we're excited to have them here as well. Then there's Cynthia Reddick, who is a registered dietitian and a certified nutrition support clinician who brings more than 25 years of experience in DME and home infusion, supporting patients transitioning from hospital to home while navigating the reimbursement and access challenges affecting enteral nutrition services. And last but not least, we'll also be hearing from Becky Wolf, who is a longtime patient advocate with Improved Care Now and a current ICN board member. She will share how medical nutrition has shaped her health and education and commitment to expanding access to those nutrition therapies. We were really grateful to have her with us earlier today. We went to visit a couple of House meetings, and she was able to share a story and really highlight why these bills that we're going to be bringing up today are important and should be taken seriously, and hopefully get some of your bosses to sign on to these bills as well. So without further ado, we're going to have our first speaker.
Thanks, Jordan. Hi, everyone. Thank you so much, Jordan. It's a wonderful pleasure to partner with you in the organization. I'm Kelly Horton. I'm the head of public policy for the Academy, and I'm here to talk about the Medical Nutrition Therapy Act. And before I jump in, how many people have heard the term medical nutrition therapy? All right, a few people. All right, great. So let me define that for you first. So medical nutrition therapy is an evidence-based application of what we call the nutrition care process that includes nutrition assessment, nutrition diagnosis, nutrition intervention, and nutrition monitoring and evaluation to help prevent or treat chronic disease. And it's provided by registered dietitians. And the Medical Nutrition Therapy Act would expand coverage, and I'll talk about why that's important. I'm going to talk about what it does, and if you are outside and there's folders out there that have some of this information and actually a whole bunch more, feel free to grab one of those on your way out if you haven't already. I'm going to talk about why access matters, and then effectiveness. There's a lot of research out there about MNT, and we'll talk a little bit about what the research shows, and I'll talk about the cost of the bill, because most of your bosses will be asking that question, and then some resources, which again are printed in the folder, but you can also find them online. So first of all, it is a bipartisan bicameral bill. It's introduced in the House by Representative Kelly and Kiggins, and introduced in the Senate by Senators Collins and Peters. And the bill, I would say, I can't put words in their mouths, but it's personal to all of the members, and you can ask them if you're talking to their staffs about those personal stories, and then their passion for increasing access to medical nutrition therapy. And really, I was excited to hear Representative McGovern talk about all of the things around food as medicine, and medical nutrition therapy is part of those discussions as well. So what does the bill do? The bill would expand coverage for medical nutrition therapy in Medicare Part B. So right now, if you're a Medicare recipient, you can get care for medical nutrition, or we call it MNT, for diabetes and renal disease and post-operative transplant renal disease. That's it. So if you were to come and see me and you had diabetes, but then I also saw that maybe you were struggling with obesity or malnutrition, that's not covered. Okay, so you'd have to pay out of pocket. The bill would increase to these conditions and cover cancer, cardiovascular disease, dyslipidemia, HIV and AIDS, hypertension, eating disorders, malnutrition, which Jordan talked quite a bit about, obesity and prediabetes, and then also any disease or condition causing unintentional weight loss, which is very difficult to counteract by yourself. So patients really need this care. The other thing that the bill does is it expands referral. So right now, if you go see a nurse practitioner or a physician's associate or physician's assistant, as we're commonly known, they can't refer you to a dietitian. Only a physician can refer you to a dietitian. Well, that's an access issue, not just in rural areas, but particularly in rural areas. Most people, their primary provider is an NP or a PA. And so I'll talk about what that does and what we're trying to fix with that piece. And just to that point, the Dr. Joyce, the head of the GOP Doc Caucus, sat down and talked with us and thought that was ridiculous and that we definitely need to fix that issue. So the bill would be a game changer, increasing access to care, reducing barriers to nutrition care. We're in a really amazing moment with nutrition right now. You cannot get the news any single day and not hear the words nutrition. And so let's put our investment where we're talking about it and make sure that people have access to the care. And then also to help solve that limited access to qualified providers. The bill would save the government, and there is a sheet in your packet. We commissioned Avalier Health to do a score of the bill. So they did it like CBO would do it, although maybe CBO would come up with a different score. But they found from the available research and evidence that it would save the government $33 million each year across all 9 conditions, with obesity alone accounting for a $38 million savings over 10 years. So that's a huge savings. And I will say, I used to work at appropriations. The bill is under $1 billion, so it does not give me heart palpitations. When something starts to get towards that $1 billion, you get a little worried. The bill is around $600 million every year. So that is not a lot for an investment. And it's sort of like if I do my job, you don't see the fire. If a nutritionist is able to do her job, we don't see the disease progression to the more costly diseases. I should say his or her. Okay, so the other piece that the bill does is to change that referral authority. So currently, if somebody comes in, and I'm going to use Kroger, they're one of our partners in our coalition. If they come into a Kroger little clinic, which employs nurse practitioners, they come to that little clinic and the dietitian is seeing the patient, the nurse practitioner is seeing the patient and says, oh, they could really benefit from nutrition therapy. Again, she or he cannot refer them to a nutritionist, a dietitian. So they have to go find a provider, find a doctor, and make an appointment, go see that doctor, potentially in person, driving hundreds of miles, maybe through telehealth, whatnot, make sure they're having to maybe do a copay. Then that doctor has to deem that they do indeed want to give a referral. Then they have to get that referral and then find a dietitian. If the bill goes through, the nurse practitioner or the physician's assistant can give the referral directly to the nurse practitioner. And I don't want to speak for Kroger, but in this particular case, perhaps Kroger could then hire a dietitian who's right there in the little clinic, and you go right next over to her and start talking to her about medical nutrition therapy. So that's what we are trying to achieve with passing the bill. Why does it matter? Jordan talked about the healthcare cost, and right now, nutrition-related diseases and chronic conditions are driving up healthcare costs in America. We're looking at that $156 billion annually. I love that our numbers matched. That made me feel really great. Thank you. Sometimes they don't when you're meeting with people. So, and our position is that we want to make sure we expand access to medical nutrition therapy. We can then help with those health conditions and those risk factors, and it should be provided by a registered dietitian. So I talked a little bit about the cost. Again, it's $649 million over 10 years, and that is scoring all the conditions. We are trying to get a CBO score, and we do have folks on the Ways and Means and Energy and Commerce committees who are interested in the bill, so we're hoping the bill can move forward in this Congress. Again, because there is an associated savings. And also, in addition to the conversation on nutrition, there's a specific conversation and interest in obesity treatment and management. And so there is an opportunity here with the research that we have done, and I'll talk about that in just a second. So this is not in your packet, but if you want it, I can send it to you. This is the specific conditions and the cost or savings associated with each one. So you can see, actually, I guess you need my microphone, so I can see it over there. So you can see that pre-diabetes, so preventing diabetes, would cost almost $150 million over 10 years. But again, we are saving people from developing to diabetes, which we know is also more costly. I want to point out 3 of these conditions. So obesity is a savings of $38 million over 10 years. Malnutrition, which Jordan talked about so eloquently, is a savings of $28 million over 10 years. And then eating disorders also has very substantial evidence of savings over 10 years of $4 million. There are some costly conditions here, but again, I think the way that CBO scores and the way that Avalier did the score to match that doesn't account for prevention. And there's another bill that is trying to change that. I think if we counted this, if we did the scoring in a different way and was more focused on prevention, we would see a lot more savings here. There's over 100 organizations that support the Medical Nutrition Therapy Act. We're really excited about that. We're excited about the bipartisan and bicameral nature of the bill that we've maintained over in this Congress, and we would love to have your boss's support. So if you want more information, feel free to let me know. Am I passing off to you or to? Okay. And you're up, Carol.
Thank you. It's a real pleasure to be here. It's been a number of years since I presented at a congressional briefing, and it's 25 years since I was sitting in that seat as a staffer, as a AAAS fellow. So I am a physician, and I'm short. And I am speaking on behalf of the patients and providers for medical nutrition equity. I have to be very clear, I'm not speaking for my current employer, not representing my day job. And switching gears here from the incredible burden and the huge impact you can make with the common complex disorders, the chronic disorders, what I am here to speak about are also chronic disorders, but we're talking about a much smaller number of people, so that the costs of the bill would be modest and the savings would be potentially larger per person, but we're talking about a smaller dollar amount, but we're talking now about not improving people's lives, but saving lives. So now we're talking about people who might, without medical nutrition, actually not be able to survive or not be able to function. So our goal here, and I need to start by really thanking the legislators who are leading this charge. This bill has been, we've been working on it since I was sitting in that seat. And before that, I actually was not around the first time that TRICARE and Kaiser decided to cover the medical foods, but I was around when TRICARE was authorized to do it again. So this is something that Congress thinks is important. So what we're talking about is, again, support from both sides of the aisle and both houses, both chambers, for the Medical Foods and Formulas Access Act, Senate Bill 3304 and House Bill 5684. And what do we mean? Fortunately, we've already had the definition of the medically necessary food and formula, and I want to say a couple of things. These are things that I prescribe as an MD. I'm specially involved in the care of people with the inborn errors of metabolism. You're going to hear a little bit later from somebody with some of the GI disorders, but I'm familiar with those as well. These are things, and these are expensive, These are things, some of my patients, a baby's medical food will cost $7,000 to $9,000 a year, and an adult, we're talking about $15,000 to $20,000 a year. And this is just for the medical food that is required to prevent malnutrition and prevent poisoning. And I should add, these things taste horrible, truly, phenomenally awful. Yes? So these are not things that people want to eat. These are not things that people are going out for because they read a paper and they think it might make them a little healthier. This is life and death. This is intended for prescription by a physician and carried out in collaboration with the nutritionist who's figuring out exactly how many milliliters we're supposed to be giving. For some people, this is the only thing they can take. And for most of my patients, they can take their medical food and, in addition, some foods. And it's not that the medical food is instead of something that you would otherwise eat and you might be a little bit healthier. One of my patients with PKU has a beautiful slide, the entire protein that she's allowed for the day from ordinary protein. One bagel is all the protein she can have for an entire day. So these are people who are getting their protein from a medical food that has certain amino acids removed. That's what makes it taste so foul. And then eating a little bit of, so it's not that they're only paying for the medical food. They have to have regular food and the medical food in addition for most of the patients. And then some of the folks with the GI disorders, they can't have any foods at all. So the history of this bill is it's introduced with strong bipartisan support in the House. We just heard from Representative McGovern, and deep gratitude if any of his staffers are here. And then in the Senate. And again, this has been going on for many, many years. This bill has been revised from previous years. It's narrowly crafted. The common complex disorders are addressed in other ways. This bill is narrowly crafted to address the people with inborn errors of metabolism. We're talking about individually rare disorders. Most of them are 1 in 10,000 people to 1 in a couple 100,000 people. So individually rare disorders. The GI disorders, Crohn's disease, for example, is a little more common than that. But the language on this bill does also give the secretary the opportunity to include other conditions, but it's narrowly crafted to address people for whom nutrition is literally life and death. So what inherited metabolic disorders are covered? They includes disorders that are on the what's called the RUSP, the Recommended Universal Screening Panel for Newborn Screening. So it's really hard on us taking care of patients and families when we diagnose a child with PKU or maple syrup urine disease, and we tell the family that they need to have this particular medical food, but it's not covered. And so we can't realize the promise of newborn screening unless we have the coverage. And then for the digestive conditions, we're talking about specifically Crohn's and ulcerative colitis, which are conditions along with eosinophilic esophagitis, where the immune system is attacking the gut, and we really need to control it with nutrition to prevent death, and also problems with growth and malnutrition, and also something called short bowel syndrome, where a child might have only, a person might lose large parts of their intestine and therefore lose the ability to absorb nutrition from the gut. Who does the bill cover? Prior versions of the bill did include private health insurance, but in order to make sure that you and your bosses would have less pushback from the community, this is really limited to the public payers. Medicaid, Medicare, Medicare is one of our biggest problems. And CHIP and the federal employers. I have one of my patients who, she has PKU, federal employee, and FEHB would not cover her formula when she was pregnant, which would be causing severe damage to her unborn child. This bill is needed to set a minimum of the coverage. States can do more, and some states have said that that insurance needs to cover the medical foods. But interestingly, some states, when they cover with limitations, like you'll cover but with a $5,000 copay, or you'll cover but we won't cover up past age 18, or we'll cover the liquid formula but not the solid foods that are medical foods. So this is needed to set a floor so that states could make access even better, but at least to make access fair and equitable across the country. There is legislative precedent that when we look back at 2016, Congress required TRICARE to cover. So in principle, this is already agreed to. And then in 2023, and there was a lot of panic in our offices when the formula shortage happened, because one of the suppliers that went down was the only one in the United States that makes some of these medical foods, and we had to get permission to import from Europe. So it's already been made clear by Congress that these are important things, that access to these are important. So currently, FEHB covers some but not all. I just gave you an example of the federal employees. Medicare covers none. TRICARE is the best of these, and medical assistance, if you can get it, is great up till age 18 or 21. Just very briefly, and again, Crohn's and the digestive disorders, not my specialty, but do know a fair bit about it. And why are the medically necessary foods important to patients with Crohn's disease? So there are other treatments for Crohn's disease. There are major drugs like steroids that we can turn down the immune system with these drugs. These drugs have side effects. These side effects can cause differences in a person's growth, in their bone density, all sorts of long-term problems. And Crohn's can be controlled with nutrition that is delivered, and again, these don't taste good, and you might be able to drink them, or you might need to take them by tube, but there is solid evidence that shows when you use these medical foods in Crohn's disease, you can decrease the percentage of people who go on to complete bowel failure, who might need major surgery, who might need to have some of these, by the way, very expensive medications with lots of side effects. And, whoops. Okay. And for the people that I take care of with inborn errors of metabolism, these are things that are present from conception. They're lifelong. These are individuals who cannot metabolize something that's normally in the diet. So just, you guys probably all remember from biology in high school or college, there's 32 amino acids. Not all of these are amino acid disorders. There are a few that are like disorders of carbohydrates or lipids, but using the amino acids as an example, there are the amino acids, and we get them in what we eat. And if you cannot metabolize valine, isoleucine, and leucine, you have a disorder called maple syrup urine disease. It's called that because the poisons that build up in the body, when they come out in the urine and in the sweat, they smell a little bit like maple syrup. That child will die if I do not give them the right formula. There's nothing I can feed them that would not either poison them, or if I reduce the protein by enough, I'm causing malnutrition. So I cannot care for this child without that formula. And properly supervised by an individual, actually one of my patients is now a grandfather, and his daughter is a chef. And I have patients with another disorder, phenylketonuria, which untreated would cause intellectual disability, severe intellectual disability, and that person is an engineer and now a father. So just examples of what we can do as long as we have access to these medical foods. These are individually rare disorders, but we get pretty passionate about them. So there are quite a lot of organizations that support this legislation. And again, it is bipartisan. And I am here because I live in DC and because I used to be sitting in your seat. And I can speak to the needs of the community. And if you'd like to hear more details about the bill, you want to contact Camille Bonta, who I'm speaking for today, but I'm also happy to answer any questions at the end here. Thank you.
I'll just add it. We are running up on the 10-minute timer, so we're gonna try and get through all this. We might go a little bit over, but at the end we'll also have a QR code to our website, and by tomorrow we'll have all this presentation and recording posted as well. And feel free to chat and eat afterwards as well, and talk to our speakers as well as some of our agency members who are here as well. Thank you.
David started on tube feeding after being diagnosed with pharyngeal cancer. He had to have radiation, chemotherapy, and he was not able to swallow. So he had a feeding tube placed in order to get the nutrition he needed. He went to the hospital, had the surgery, went home, and then he got linked with a home care company. We have home infusion companies and durable medical equipment companies. We call them DME companies. And they were providing his supplies. He needed formula. We've been talking a lot about formula that had to go through this prosthetic, through this feeding tube. And he had clinical care and dietitians that were supporting him through that organization. Well, he got better. He graduated off of his tube feeding. They had the tube removed. And then a few years later, his cancer came back. So he had to have the tube replaced. And at this time, his prior home care company was no longer serving his community. So he decided to do it on his own, and made sense. He rebuilds cars. He, knows how to, carve things out of wood and use all these fancy tools. So he's thinking, I can do this tube feeding thing. And he did until he didn't. And he was having a tremendous amount of problems with leakage at the stoma site. So he called his doctor after going into the ER a couple different times with this leaky tube site, and the doctor decided the right thing to do would be to upsize the tube, meaning make it a bigger diameter, a bigger French size, so that the tube would stop leaking. Well, that didn't work because he found his way to me, and what I learned after having some conversations with him is that he was feeding too much too fast. He was overfilling his reservoir, and that's why he had a leaky tube. But he didn't have the clinical support through the home care company he had been working with in order to troubleshoot this. So David's story will be a red thread through the rest of what I have to say. And the theme today is access, and I'm going to talk a little bit about that. So we've talked a little bit about nutrition, what home enteral nutrition is. That's what HEN means. It's the nutrition that we feed through a tube with a functioning gut. And, it is covered by Medicare under certain circumstances, and it's tucked under the prosthetic device benefit. And that makes sense because that tube is a prosthetic for a malfunctioning esophagus. So that's how that works. And there's a variety of different disease processes that lead somebody to the need for a feeding tube being placed. Do any of you in the room have family members or have a friend or know of a child or an older person who has a feeding tube? Has anybody ever seen one in the wild? Okay, that's what we call it when they're out in the wild. And there's more than you think. There's over 220,000 patients on HEN or home enteral nutrition. My name is Cynthia Reddick. I'm a registered dietitian, and I am very passionate about this subject, working in home infusion and DME for over 25 years. And we're here talking about a couple of federal bills, HR 2005 in the House and S 2951 in the Senate, that directly affect whether patients who depend on home tube feeding can continue to receive that care like David needed. It isn't abstract policy, it's formula, it's pumps, it's supplies, it's the tubing, it's all the things, and it's helping it get delivered to that patient's front door. But let's talk about what's at stake. Here are the mechanics. Our government has a program called competitive bid, and it's a way to reduce cost. And it sets how much Medicare pays suppliers, these home care companies, including enteral nutrition suppliers. When they applied these competitive bid prices everywhere, it created this payment cliff, especially outside of major metro areas. This bill is very specific to areas that are not rural, but they're outside of what we call CBAs, these competitive bid areas. And Congress temporarily softened this with what we call a 75-25 blended rate. It's a calculation that split the difference between an artificially low bid price and the real fee schedule. It was basically a little bump in reimbursement. The relief expired. So this is what's important to know, is that the relief expired at the end of 2023. So our home care companies are receiving less payment for this population of patients, and it probably makes up close to 50% of a home care company's census. So these bills put it back, and the Senate version would also block the next round of competitive bidding from making things even worse for these home care companies. So importantly, this is bipartisan. Both sides recognize the access problem. The numbers speak for themselves. This is some data that came from a supplier survey that AA Home Care did. They did one in 2023, and then most recently in March, they sent another survey out to home care providers to learn about their experience. So I'll tell you what it feels like from inside a company. I used to work for one of these large national companies. Picture a mid-size or large or even a small home care supplier where margins are already thin, and the cost of everything they touch has gone up. Everything from the formula to the pumps to what we call consumables. These are the bags and the syringes and everything that we use to administer tube feeding has gone up. And a new thing with the tariffs is also occurring where the manufacturers are having to pay those tariffs, and they're pushing those costs down. They're not holding on to them. Most of the time, the manufacturers don't absorb those extra costs, they push it down. And when the payers don't increase their reimbursement, who's absorbing those costs is the home infusion companies and the DME providers. So through this is what breaks that payment model. The Medicare check hasn't really moved and the reimbursement has been rather flat except for a small inflation bump. And every cost is climbing at once, but the one revenue line is frozen. That's the reimbursement. Every other industry in business has a name for that. It's called a disappearing margin. This is the math behind every supplier and a supplier that's considering closing or has already closed. They're thinking about it. The economics have stopped working, and the breaking point really is on the next slide. So these surveys have also asked suppliers about their position and are they considering exiting the market. These are not projections, what you're looking at here. This is what's already happened. So this has been a trend over the course of a decade. When competitive bid began in 2014, I was there for it. It was extremely painful. Our reimbursement was cut in half. And so adjustments needed to be made. There were a lot of companies that flooded into the space to move into a drop ship model, which is not a very clinical model. They just drop ship boxes. They're called box movers, and they're not doing anything to actually raise the level of care for these patients. But since 2014, these suppliers are down 31%. Medicare patients actually receiving their tube feeding supplies through a provider is down almost a third as well. And that's not to say that there's a decrease in consumers. That population, our Medicare population, is growing. You know this. And so for the data to tell us that fewer Medicare patients are receiving home tube feeding is sort of it's David's story. It's a dangerous story. So a couple of years ago in that survey that AA Home Care did, 1 in 4 providers was considering leaving the business. Today, almost 60%. Everybody's talking about it. A majority of the remaining suppliers are weighing the exit. Many of these suppliers do other businesses. They might have home infusion like TPN. They might do oxygen, DME, walkers, wheelchairs, things like that. And they're relying on that business to cover the deficit. But they'll only do that for so long. I was part of a company that only did it for so long. And then they laid off 2,000 of me and 2,000 of my closest friends in order to save money and closed down half of their branches. So that was a big impact to access. Where did all of those patients go when their home infusion company closed their doors in their neighborhood? So here's something that often gets lost in the policy discussion. Medicare reimburses for the product, the formula, the tubing, all of the bags, but not the clinical support behind it. It's something that we call a value add. So for the companies that I've worked for, we did it because it was the right thing to do. It's if you're dispensing these things, you should also have the clinical care to support these patients. We know from Kelly that Medicare's not paying for dietitian services for these patients. It's not considered a disease. You know, having a feeding tube is not a risk factor for malnutrition. You better believe it is, but it doesn't cover the dietitian's care. Home tube feeding suppliers do far more than deliver formula. They do the training and patient education. Before somebody leaves the hospital, they have to be trained on how to use their new prosthetic. It's usually the home care company that's doing that work. So competitive bidding programs are designed for commoditized DME, something that you can just drop ship and not have any real clinical care around it. It's not, it's these types of companies are interchangeable in that way. Enteral nutrition, and I hope this is an important takeaway for you, it's not truly commoditized, even though it's shoved into this bucket of a commodity DME. It requires ongoing assessment and coordination, and when reimbursement is reduced under the commodity-based models, the service layer is what gets cut first, and that's when our patient risk goes up. So let's be clear about what failure looks like. Suppliers disappear, access to medically necessary formula breaks down, hospitalizations increase, and the families and people like David are left to figure it out and find their way to a dietitian to help them. So I want to address a question that sometimes comes up in policy discussions when you're talking with your bosses. I want you to think about this. Is this actually a good value for Medicare? And the answer is clear. Home enteral nutrition, even with adequate supplier reimbursement, costs a fraction of what it would cost for that patient to go into the hospital because of a problem related to their tube feeding, something that their home care company could help support them in to keep them home. Everybody wins when these patients stay home instead of going into the hospital. So when we underpay suppliers to the point where they exit the market or they scale back their offering in order to save money, we shift costs to a much more expensive model, and we strip patients of the quality of life that they deserve on tube feeding. So I have two asks for you. Write this down. Support HR 2005 and S 2951 and restore the payment floor for the non-rural, the non-CBA areas, and also shield from further cuts. And ask for a pause on the competitive bid expansion. We need to study the access impact, and we need to hear from small providers, the neighborhood providers in more rural areas, and the larger providers that are having to actually exit this space. We're already losing access. It's accelerating. I'm here to tell you that, and these steps stop that trend. Thank you very much.
Thank you all for sticking around. I know we're a couple minutes over, but I'll be pretty quick. My name is Becky. I am a Crohn's disease patient, and I'm here to kind of weave together what our incredible speakers have talked to you about as a patient who's used multiple of these forms of alternative nutrition. I've been doing patient advocacy with Improved Care Now for almost a decade now, and have had the privilege to talk to a lot of people about my experience with nutrition. So thank you all again for coming today. I remember when I was 8 years old and I was sitting on the side of a soccer field watching my twin sister play, but I couldn't join. I was on the side with my parents in a winter jacket and gloves, even though it was the middle of spring. And this is because I was so sick that I didn't have the energy to keep myself warm, let alone play on the team. Crohn's disease can be really aggressive in children. It's a disease that causes intestinal inflammation, which makes it really difficult to grow normally and be able to thrive. I was very malnourished as a kid, and doctors classified me with failure to thrive. I was actually so much smaller than my twin sister that people would regularly ask how many years older she was, even though I was a minute older. But nothing really helped me gain weight. I tried a lot of very expensive medications with a lot of unpleasant side effects, like steroids, immunosuppressants, injections, and infusions, but none of it worked until I tried these forms of specialized nutrition. For kids with Crohn's like me, eating can be really painful. I remember being in the bathroom with my mom as a kid, crying after trying to eat dinner. Struggling to get enough nutrition wasn't just about the intestinal inflammation that made it difficult to absorb these nutrients. Bringing myself to eat as a kid, knowing the discomfort it would cause, was extremely difficult. This is why my doctors suggested oral nutrition supplements, like Boost or Ensure. They're much gentler on my stomach and helped me tolerate getting nutrition when I couldn't tolerate solid foods. I drank these for a long time, but it became overwhelming to drink as much, as my doctors were aiming to have 100% daily calories through these formulas. My doctors then transitioned me to enteral nutrition, a nasogastric tube placed through the nose into the stomach. I was 9 years old. I went out of state to a hospital to learn how to place these tubes myself, and I did so for 5 nights a week for 2.5 years between the ages of 9 to 11. I missed a lot of sleepovers, and it was very difficult, but it was the only thing that ever helped me grow. You may be able to tell I never caught up on the height curve. There have also been times where medical foods have been the only form of nutrition available to me. In my freshman year of high school, I got hospitalized for the first time when my doctors discovered that my colon was closing or obstructing due to the intestinal inflammation and scar tissue. They gave me 2 options: have my colon removed the next day in an emergency surgery, which would forever change my life, or stop eating entirely while doctors raced to find a solution. I chose the latter, and for months I was allowed to eat almost nothing except for clear liquids. My only source of real nutrition was TPN, or total parental nutrition. This was a line in my arm through the vein that delivered nutrient-dense formula into my blood, bypassing my digestive system. I eventually did have my colon removed because of Crohn's disease, but TPN bought me precious time to try other options. Even better, it made me healthy enough that I could leave the hospital and finish my freshman year of high school on time. And I even attended and participated in the school play with my TPN line and pump running. I was really lucky to afford these treatments. My parents' insurance covered the enteral equipment formula and the TPN formula and equipment, but my parents had to pay out of pocket for the oral nutrition supplements like Boost and Ensure. Those forms of nutrition are very expensive, and that's why I donated my NG tube feeding equipment. And that's why I've pursued a career in health policy to make healthcare more affordable and accessible. I also could have had many reduced costs and medications if I'd had access to this earlier. 3 surgeries and 4 hospitalizations later, patients who have Crohn's disease like me, but can access these forms of nutrition, can go into induced remission. Their disease can become inactive for a significant period of time. After years of enteral nutrition, I was finally strong enough to join the soccer team with my twin and all of our friends. I really struggled with this disease throughout childhood, so something as simple as joining a sports team, as terrible as I was, and I mean really terrible, it did mean everything to me, a kid just trying to be normal. There are a lot of patients who need these forms of nutrition but can't afford them. My story should be the story of all patients, being able to get the care that they need when they need it. Thank you all so much for coming and listening to this wonderful panel, and I hope we can work together to make these forms of nutrition more accessible and affordable for all the patients who need them. Thank you.
Yeah, thank you all for taking the time to speak with us today. I know we've gone over. Just wanted to close out by saying, we still ask you guys to continue supporting us and protecting patient access to medical foods and oral nutrition supplements. Just please recognize the importance of oral nutrition supplements in food and in medicine legislation. Here are the bills that we talked about today in great detail. Just also want to mention that this is our QR code to our website, so if you scan that, you'll be able to have access to that by tomorrow early afternoon, 12 o'clock at the latest. We will have all the PDF files up, as well as a recording of this briefing will be on our website by the end of this week, Monday at the latest. So just clarifying that as well, that you guys will have access to these resources. If you didn't pick up the folders on the way here, there are some outside as well for you. And please feel free to get more refreshments before you head out for the day. And thank you for staying extra. All right, bye.